Hello, everyone, and welcome to our Friday webinar series. I am super excited to have every single one of you joining us today. We are talking about champions for total health, cancer and vaccinations, and the intersections of both. So, my name is Kristen Hobbs, and I am the Director of Quality Improvement and Equity at the National Minority Quality Forum, Center for Sustainable Healthcare Quality and Equity. Again, we want to take care of a few housekeeping issues while everyone is joining us. And I want to make sure that everyone has an opportunity to know that your audio and video are turned off because you are in listen-only mode. The chat will be available though, so please, please, please use it. We welcome respectful, transparent feedback and communication in the chat. This webinar will be interactive towards the end, and so we will use the chat as well to do that interactive portion. And we would like to ask you to place all of your questions in the Q&A box because that's where we will be fielding our questions from the Q&A section. So to get started, here is our agenda. I'll talk a little bit about NMQF and SHC. Then we'll move into vaccine data and vaccine recommendations for cancer survivors. We have a little bit of change in agenda today while our third panelist joins us. And then once Dr. Doroshow joins, we will talk about cancer inequities and the risks.
Oh, I'm here, Kristen.
Oh, you're here. There she is. Hi. So we won't have a change in agenda. It's so good to see you. And then we'll have a patient advocate perspective. I'm super excited in every single one of these Friday webinars that we have when we talk about total health to be able to talk to someone who's been through the very thing that we're discussing. Then we'll do our microsite feedback where I will take you through a sample draft version, if you will, of the microsite that we've developed to go with this content. And you will give us feedback on how to make it better, how to make it culturally appropriate, culturally responsive, and linguistically appropriate for our audiences. And then we'll go to Q&A. So first things first, NMQF. So our goal is to reduce patient risk. And NMQF was started in 1998 by Dr. Gary Puckrin. To reduce patient risk and advance health equity, we use evidence-based tools and data and best practices to inform all of our work. And at SHC, we work to create sustainable, healthy communities in every single zip code through quality improvement, clinical education, and public health interventions via a lens of health equity. So that's where all of that health equity piece comes in. All of our models and frameworks that we work within are used with health equity. Our president is Laura Lee, you know me already, and my colleague Chenny, who is in the background helping me out with this webinar today, is our Quality Improvement and Equity Project Manager. So without further ado, I would like to introduce Dr. Doroshow. She is an assistant professor of medicine, hematology, and medical oncology at the Icahn School of Medicine at Mount Sinai. And Dr. Doroshow, please feel free to let me know when you're ready to advance.
I am ready. Good afternoon, everyone. Kristen, do you want to switch to the next slide? So I have a few different roles. I'm a medical oncologist, so I take care of people with a wide variety of cancers, especially lung cancer, and I also treat people on clinical trials. And another reason why I'm probably here today is because I've been very involved in work on how COVID-19 has affected people with cancer, and how there have been certainly been numerous inequities with respect to that. So just for a very broad overview. So the National Cancer Institute defines cancer as a disease in which some of the body's cells grow uncontrollably and spread to other parts of the body. And the way that I like to explain this to patients and families is that essentially all of the cells in our body are always growing and dividing and making new cells. But cancerous cells are different because they're growing and dividing in an uncontrolled way, faster than the normal cells in our body. Next slide. So there are many different kinds of cancer. We typically think about blood cancers and solid cancers. So blood cancers are things like leukemias, lymphomas, multiple myeloma, for example, whereas solid tumors are things like breast cancer, lung cancer, liver cancer, colon cancer, and so on. Sometimes tumors, which are collections of cancerous cells, can be benign. Most of the time, though, when I treat people with cancer, we're talking about malignant tumors. And that just means cancers that are growing out of control and have the propensity to spread to other areas of the body. We use something called staging to talk about where the cancer is in someone's body. And you may have heard things like stage 1, stage 2, stage 3, stage 4. Sometimes people use the word metastatic, which usually means stage 4. And the definition of that word, which can be a really scary word, just means that the cancer started in one place and it traveled to another place. Not all stages of cancer are curable, but have a multitude of patients who are living very full lives with advanced cancers. Next slide. Great. So you may or may not be aware that multiple cancers are actually related to viruses and can be prevented with vaccinations. And I'm not talking about any unusual vaccinations, but vaccinations you can get at your primary care doctors. And so one kind of cancer that I treat is called hepatocellular carcinoma. Of course, we doctors like using non-English words for everything, and that's just a complicated way of saying liver cancer. And there are many different ways that people can get liver cancer, but one of them is by contracting the hepatitis B virus, which is very common. It's spread through contact with infected bodily fluids or from mother to fetus. And over time, it can cause liver damage and ultimately can be associated with liver cancer, although certainly not for everybody who gets hepatitis B. It's a very treatable disease, but it's also a very preventable disease. And the vaccination protects nearly 95% of healthy infants and over 90% of healthy adults. So, you know, we of course are getting many new ways to treat cancers and help people with cancer feel better and live longer. But what we like even more is to prevent them from ever happening. And so it's really exciting that we have a vaccine that can help prevent a kind of cancer. More recently, especially over the last 10 years, you may have heard of the HPV vaccine. So HPV is the human papillomavirus, and it's a really common virus that can lead to many different kinds of cancers. Usually most people are aware of the connection between HPV and cervical cancer, especially because it's been in the news a lot and because when the HPV vaccine was first approved some 10, 15 years ago, that was really the focus. But it turns out that a lot of people with other kinds of cancers can also have HPV that was involved in the development of their cancer. And the other most common kind of cancer associated with the HPV virus is head and neck cancer. And these are cancers that can happen not in the brain, but rather in places like the mouth, the throat, and the neck. And while many of these were in the past mostly associated with people who had smoked cigarettes in the past, more and more we're seeing that these cancers are related to this virus. And HPV is spread through intimate skin-to-skin contact with somebody who has the virus. The vaccine is nearly 100% effective, and studies show that the protection that it affords does not decrease over time. So this is probably one of the most exciting things in cancer prevention really over the last 50 years. And whereas people have been focused very much on cervical cancer, which is very important, one thing I just again like to stress is that this vaccination can help prevent head and neck cancers, which are also, you know, can be very challenging to treat because they're in a sensitive area of the body. So this is just another area we're very excited about. Next slide. And then one thing that we are constantly dealing with, because health and medicine do not exist in a vacuum. They exist in our society and in our culture. So you may be familiar with the terms disparities and inequities. Sometimes people kind of conflate the two, but they're actually a bit different. So disparities are really differences. They're differences of any kind, differences in cancer incidence, in cancer outcomes, based on factors that might include race, ethnicity, age, income, sexual or gender orientation, where somebody lives. So you might say that, for example, if we were talking about lung cancer, it actually turns out that there's a whole lot of the chemical radon in the state of Utah. So the incidence of certain kinds of lung cancer are higher in those areas of Utah than they are elsewhere. That's a disparity. You might also say that more people with breast cancer are women. So that's a difference. Inequities are where we really start talking about structural racism that contributes to barriers that prevent individuals and communities from accessing high quality healthcare and reaching their full potential. So what we really want is for every single person, either with cancer or at risk of any cancer, to be able to get the same high quality treatment and preventive care. Next slide. And cancer inequities really occur across the cancer continuum, from prevention to detection, diagnosis, treatment, and so on. And, one can point to several drivers, but I think they all really lead back, especially in the sense of racial and ethnic equities, to structural racism. There are certainly inequities in socioeconomic status that are deeply embedded. For example, access to insurance that supports basic preventive care. Now, Obamacare sort of actually demanded that all individuals be able to access preventive care. But if you don't have a way to get to a colonoscopy, then a colonoscopy can't help you. And so these are very realistic things. Real life can get in the way. So even if we have the best tools possible, if people can't access those tools, they can't help them. For example, Black men have the highest overall cancer mortality rate, and cancer is the leading cause of death in people with Asian and Pacific Islander backgrounds, as well as being the leading cause of death among people of Hispanic and Latino backgrounds. One good example of a cancer inequity is that we know that even if they have the same economic background, for example, Black women with breast cancer have poorer outcomes than white women with breast cancer. And there is no scientific or medical reason why that should be the case. And so that's a deep societally based problem that is really a matter that needs urgent intervention. Thanks. I think that's the last slide, Kristen.
Yes, it was, and I was just struggling to get off mute. Thank you so much, Dr. Doroshow. Thank you for illuminating around the social, determinants of health and how those can be drivers. I also wanted to add that there are political determinants of health and systemic determinants of health as well, in which structural racism exists and plays a vital role in how these inequities are perpetuated. So now I want to punt it over to Dr. Fiscus, who is a board-certified pediatrician, public health consultant at the Association of Immunization Managers, and a cancer survivor. Welcome, Dr. Fiscus.
Hi, Kristen, and good afternoon, everyone. It's wonderful to be with you. And I will take my first slide, please. So just continuing on with what Dr. Doroshow was saying, vaccines are really important overall. They're especially important for people who have a history of cancer. And generally, if you're undergoing cancer therapy, radiation or chemotherapy, we generally don't give vaccinations during because the cancer treatment is impacting the way the immune system works. And so it's not that these vaccines would necessarily harm you, but that you might not produce the kind of antibody response or the kind of protection that we would expect to see from those vaccines if at the time that you get them, your immune system is weak. There are a couple of exceptions to that. One is flu vaccine. It's very important that everyone ages 6 months and older get an annual flu vaccine. And I know some of you listening might say, you know what, I've done that and I've gotten flu anyway. Very similarly to what we say about COVID vaccine, flu vaccine makes it so that if you get flu, which there's some chance that you still would, the chance of you being hospitalized or dying from influenza becomes very low. So just like the COVID vaccines, while it's possible that you could still get an infection from an influenza virus or a SARS-CoV-2 virus that causes COVID, if you were vaccinated, the chance of you getting hospitalized or dying because of those infections becomes very small. As a matter of fact, we almost exclusively see that the children that die from influenza each year were unvaccinated. So if someone is going through cancer, chemotherapy, or radiation, it is recommended that they get a flu vaccine. We usually start vaccinating against influenza around August, and that influenza season can start sometimes as early as October or so. It's pretty variable when that season begins, sometimes October, sometimes we won't see it until Christmas or maybe even after the new year. And then generally is gone by February, March, but we can see influenza circulating sometimes as late as May or June. So each year it's very important to get those vaccines to be protected against that. Next slide, please. With people who have a weakened immune system who from cancer treatment who are getting COVID-19 vaccines, the recommendation is that instead of getting just 2 doses of the Pfizer or Moderna vaccine, that you actually get 3 doses. And then you still go on to get the boosters that are recommended, which is 1 booster if you're between the ages of 5 and 49, and a second booster if you're over the age of 50. So we do want people who are undergoing cancer therapy to be protected against COVID-19. The COVID-19 vaccines cannot give you COVID. So all they can do is protect you against getting infected with that virus and having a serious life-threatening infection from it. Next slide, please. People who don't have a weakened immune system who have cancer, but whose immune system is not impacted by cancer chemotherapy or radiation at the time, can go ahead and get just 2 doses of the COVID vaccine, the mRNA vaccines, just as everyone else is doing, and then they would get if they're over the age of 5, 2 boosters if over the age of 50, or you could get the Janssen J&J vaccine for the first dose, and then get boosters with one of the mRNA vaccines, the Pfizer or Moderna. So basically, if you have cancer, but are not currently in treatment that is impacting your immune system, you get the regular schedule of COVID-19 vaccines that everyone else is getting who doesn't have that history of cancer. Next slide, please. So one of the good things that we've seen is there's been a lot of work around trying to get access to COVID-19 vaccines to people who maybe have a harder time reaching healthcare. And that, just like Dr. Doroshow was saying, sometimes people can't get to a clinic during working hours because they have a job, or they're only available evenings or weekends, or maybe they live in a part of the country where there just isn't great access to healthcare. There's been a lot of work around this and trying to improve those disparities that Dr. Doroshow was talking about. And we've seen some really nice success in this. And so when you look at this graph, the gray bar is the percentage of the population that is that particular race or ethnicity. And then the darker blue bar is the percentage of that population that is fully vaccinated. And the light blue bar is the percentage of that population that has had at least 1 dose of vaccine. And completed all of their doses in the last 14 days. And what we've seen over time is that really the most hesitant population for getting a COVID-19 vaccine right now are white males who are generally in the southern part of the United States. So we have seen some nice improvements in the vaccination rates among Hispanic Latinos and Black African Americans, we're no longer seeing that disparity with getting people fully vaccinated. And as a matter of fact, we're starting to see that the white population is less vaccinated than some of the minority race or ethnicity populations have been. Next slide, please. Where we're not seeing good news right now is in getting boosters. And so if you look at this graph in the green is people who have gotten a booster when they were eligible to get one. And in the yellow is the percentage of that group that is eligible to get a booster and has not gotten a booster. And so for Black African American, Hispanic Latino, American Indian, Alaska Native, more than half of these folks have not yet gone to get a booster. And so we've got work to do here. Where we are really concerned about this is as we continue to see the evolution of this virus into new variants. And so we're on Omicron BA.4 and Omicron BA.5 that are coming into the United States. There is less protection from natural immunity or people who've gotten infections in the past. And there may be less protection with just these initial vaccines that were given. So people who might have been real comfortable that they were protected with their vaccines that they got maybe 6 months or a year ago may actually be vulnerable to getting infected now. And so we want to make sure that we're doing everything that we can to encourage people to go in and get those boosters. And some people will say, well, I've already gotten 2. I don't see why I need another one. Maybe the shots aren't working. And, I kind of think about it like this. If you know anyone who's diabetic, they get a shot of insulin, and that shot of insulin helps them. It actually saves their life while they're taking that insulin. But over time, that insulin and the impact of that insulin goes away, and they need to take another shot of insulin to get that system working again. And if they don't, they're putting themselves at risk for having terrible, devastating effects of diabetes. We can kind of think of this in the same way. You got a shot to protect you against COVID-19. And then after a little bit, the immunity for that started to decline. So it was recommended that you got a second shot. And over time, and with this evolution of new strains of the virus, you are again at some risk of getting COVID-19 and you need a third shot. It's not that the shots aren't working, it's just that things change over time, and we need to continue to boost that protection that we have. Even if you end up getting COVID-19 from one of these variants, the chance of you ending up in the hospital or being so sick that you're in the intensive care unit or so sick that you end up dying from that infection is very, very small compared to someone who does not have the protection of these vaccines. So we really want to encourage everybody who is eligible for a third dose, which is everyone 5 years and older, or even a fourth dose, a second booster, which is pretty much everyone who is over the age of 50, to go out and start getting those done now so that you're protected. Hopefully in the fall, we're going to start seeing what's called a bivalent booster. Moderna actually has one in development right now. And that booster would have the original strain that the first Moderna vaccine was made from, and then an addition to it that would cover the Omicron variants. And we're hoping that we're going to see that in the fall. But in the meantime, it's really important that we get protected with the vaccines that we have now. So that, I think, is my last slide. I'll turn it back. Oh, I've got one more. So just on flu vaccine, again, the importance of getting flu vaccine. We don't like to think about flu coming so quickly, but it's already the end of June, and we'll start vaccinating against influenza for the season in August. So we saw over the 2019-2020 flu season and then the 2021 season that there wasn't a lot of difference from population to population. Maybe the overall rates went up or down just a little fraction, but still we're only seeing about 50%, and in some populations only about a third of people getting annual flu vaccines. So we really hope that this year for the 2022-2023 season that we're going to have people people out and getting both their COVID boosters and their annual flu vaccine. And I think that was my last one. Thanks, Kristen.
You're welcome. Thank you so much, Dr. Fiscus, and thank you for elaborating on how those boosters can help protect us against variants and that bivariant booster that might be coming in the fall. I want to turn it over now to Leeann Medina-Martinez, who is the Disparities Program Coordinator at CancerCare. Thank you so much for joining us, Leeann, and offering your perspective. And now I will give you the floor.
Thank you. Thank you so much. Good afternoon. It is a pleasure for me to be here with you all. And I just want to talk a little bit about, the caregiver patient experience when it comes to cancer and vaccinations. Keeping in mind, everything that has happened as far as gaining access to COVID-19 vaccinations. And I think that the common theme in everything that we've heard so far today is being informed, being educated, and getting information. It seems to be one of the biggest challenges in understanding, what are the benefits of getting these vaccinations, how do they help us, and being part of the cancer community. There's always concerns about being safe, being protective, whether you're in active treatment or whether you are taking a break from treatment. It is hard to decide, should I get this vaccination? Should I not? I want it. Where do I get it? And all of it comes down to understanding, what is being offered. What are the vaccinations for? How do they help you? How do they help protect you and your loved ones? So one of the things that we talk about a lot, with cancer patients is just getting education, asking questions, talk to your providers, talk to community advocates, talk to people who's going to give you information about the facts and the benefits of getting vaccinations. A lot of the times we hear opinions, we hear commentaries from other people, and sometimes that can be a driving force into whether we get vaccinated or not. Do we just get the initial vaccines and not the boosters? So it's important to just be as educated as possible. And in getting that education, you want to make sure that you're understanding what you're being told. Sometimes we hear medical terminology that we don't understand, and it's okay to ask. It's okay to ask for people to break things down, make it simpler, make it something that you can understand in order to make the best decision for yourself. Your health is important. And as a cancer patient, you want to make sure that you're taking care of yourself in more ways than one. And vaccinations are definitely a part of that. You also want to think about and consider, being outside with other people, being surrounded by other people, having some kind of social life is also important. We want to think about your physical health as well as your mental health. And that takes part in that, being vaccinated, getting information about vaccinations. That also determines, who you can be around, how much you can engage with others, and how much you're able to enjoy, the time. The summer is usually a good time to be around other people, to, get some sunlight if you've been home. COVID impacted how much we can spend time together in large group gatherings, small group gatherings, and there's still definitely a lot of restrictions around that, but it's all for the health and safety of everyone that's together. So as far as caregivers and patients, always suggest, make the decision based on what's going to work for you, but keeping your overall health in mind. You want to take care of yourself, take care of your body, and just make sure that you're doing as much as you can on your part in order to keep yourself healthy. There are sometimes barriers as far as understanding in language. If you're not a native English speaker, if you need assistance, it's important for you to ask for that. Don't feel any shame of asking questions or asking for things to be broken down, as this is something that we come across. Advocate for yourself. Tell people what you're needs are, what your fears are, what are your questions, and get all of those answers in order to help you make the best decision, moving forward. And if you ever need other people to talk to family members, talk to friends, there's plenty of groups out there that are willing to help, to provide information, and also help facilitate, whether you need assistance, getting to these appointments, to get information, whether you need someone to accompany you, whether you need some kind of translation services. There are services out there, and you just need to ask the questions in order to be guided. And I hope that you guys take all of this that I just shared with you as quick tips that you guys can use and share with others. Thank you.
Thank you so much, Leeann. Again, struggling to get off mute today. I don't know what the problem is. But that was super informative, and thank you for giving that patient and caregiver perspective. I think a lot of times we miss the opportunity to just ask what it is our patients need from us and our communities need from us. So thank you so much. All righty, now let's move into the microsite feedback section of our webinar today. So you will be giving us interactive feedback in just a few seconds. This whole concept was birthed out of the fact that our communities were telling us vaccinations are not the only thing that are important to us. We are very much interested in our total health. So are you, as a public health field, interested in our total health? And so we didn't want to forget about vaccinations, but we wanted to make sure that we understood the intersections of the many therapeutic disease states that historically excluded communities have inequitable outcomes from, and how we can understand them in the context of protecting ourselves from infectious diseases or vaccine-preventable chronic illnesses, and give out that education. So far we've done chronic kidney disease, Black maternal health, and the pandemic's toll on mental health. And all of those microsites are available. We will be sending out an email after this with all of that information. So don't feel like you have to go search for it on the internet. And we will go into our feedback session. So let me stop sharing and reshare. And again, we truly, truly, truly welcome and appreciate all of your feedback. So please, please, please do not hesitate to tell us where we're doing well, where we're going wrong, and how we can improve. All righty. So here is the first draft of our microsite for cancer and vaccines. As you can see, we have several sections that do a deeper dive into all of the things that we talked about today. So we will be defining cancer. We'll be talking about vaccine-preventable cancers in a more detailed way, more robust way, inequities in cancer outcomes, flu and COVID in cancer. We'll have that patient caregiver / patient advocate testimonial. So every single microsite includes a 2.5 to maybe 5 minute clip of that perspective, so that people are allowed to see, someone like Leeann's perspective in perpetuity. And then we always post our webinar recording for everyone to see afterwards, just in case you missed it or you want to share it with your networks. And for this particular one, NMQF at large has a lot of cancer work going on. So this website includes that, and then we cite our sources. Another thing that I want to point out on our microsites is that after every single section, we usually have resources, unless it's a difficult topic. So for instance, the pandemic's toll on mental health was a really difficult topic to navigate for a microsite. So we coupled all of the resources in one section. But for this one, we have resources after every single section. So if you need to go back and study more on this, if you want more talking points to share with your communities, that is available to you as well. We also like to use graphical imagery in our microsites so that we can do our best to be culturally representative without having to deal with the lack of culturally representative images available to us on the internet or available to us via other organizations. We know that that's a disparity as well when it comes to just talking about health. Imagery just isn't there when it comes to those real, genuine images. And so we try to use graphical representation. And then I think that's it. So of course, again, the microsite goes on to detail some more resources, our testimonial and our webinar, and then our NMQF cancer work is at the bottom. So what I will do now is take it over to our Jamboard for us to get your feedback. My colleague Chinny, as I expressed earlier, will be helping moderate this session. So she will be looking through all of your feedback in the chat, as well as myself, to answer the questions and take notes. So without further ado, I think we can have our first poll question come up. So who would you share this cancer microsite with? Colleagues, family, friends, patients, social media audience on any platform, or is it all of those people? So please go ahead and take that time to answer. And also panelists can answer as well. I'll give you guys a few more seconds. We really do need to insert the Jeopardy thing here. All right, so Keiko, what do we have? What are our responses looking like? Okay, 82% of you said colleagues. I think this information is very important in our field in medicine and science. Family and friends at 77%. I think is very important when we are, advocates or when we're professionals, that we learn to temper how we deal with our family and friends when it comes to always educating folks on this information. But you have something that's easily digestible already at your fingertips that you can just send them the link. And then at 59% equally, everyone said patients and social media audience. So thank you for that. All right. All right, Chinny, I am going to let you, oh, she's got everything. Cool. So we're going to move on to the next frame with our next question. So on the website, the microsite sections that you saw, if there's anything that you notice that's a vital piece of information or a vital section that we should include, please let us know in the chat box. The number one thing and you can start now, the number one thing we want to do is make sure that we're inclusive of all pertinent information, especially that's relevant to cancer survivors. And communities of color and historically excluded communities. We don't want to miss anything, obviously. So I'll give you a couple of minutes and I will take a sip of water. Very, very good cancer support group information. I can't even believe we missed that, but thank you so much. We will definitely include that. Myths about vaccines. That's a good one. Myths and misconceptions. I like that. I think we're also overly inundated with misinformation and disinformation these days. Anything else? All right, well, I'm going to move on. Oh, please be sure to include information that is also relevant for older adults. Yes. Thank you for that. Thank you. Give Chinny a second to take that note. And then I think we are ready to move on to the next question. All right. Cancer and other comorbidity info. So people who are living with comorbidities as well as cancer. Okay. All right. Awesome. Thank you so much, Jenny. Oh, Ms. Vivian said cancer clinical trial promotion information and recruitment of African Americans and other minorities. So clinical trial diversity and equity. I'll go back to that one so we can make sure we get that on there. Oral health and cancer. That is a good one. So I'm so glad you mentioned this. I've become this like real hard, fast dental public health nerd, and one of my colleagues and I were talking about the education that's needed for people to understand this very correlation. So thank you. COPD and lung cancer. We will actually have a total health webinar on lung health. I believe it is in October. So please, please, please look out for that one and rejoin us again because we'll be talking about lung health and vaccinations. So we're going to keep putting information in the chat because we will have a copy of this where we'll be able to update the Jamboard later and use that to update our website and inform our materials. Okay, so next question, what additional challenges from vaccine-preventable diseases exist for cancer survivors? I think Leeann did a wonderful job of just elaborating on what Dr. Fiscus and Dr. Doroshow had already mentioned when it came to the social determinants of health, and really how do we ensure access appropriately for all of the things that affect our health, where we live, work, eat, play, and pray, so that people are able to access vaccines. And in thinking about that, I always think about the challenges of just sometimes being tired. I have been affected by cancer a lot. My grandmother passed away from it when I was 17, and she was just too tired sometimes. She just did not want to get up and go get vaccines or go do anything. And so I completely understand it. And I think that's a gap that we don't often think about. And yes, thank you for your feedback. We really appreciate it. If there's nothing for this one, that's okay. We can move on to the fourth question. Ms. Vivian says she doesn't see the questions. Are you able to see our screen, Ms. Vivian? Because we're doing the first question was a poll question, so it came up. Okay, so the first question was a poll question, so that was populated via Zoom. The rest of these are open-ended. So we're sharing them now via our shared screen. Unfortunately, Zoom technology has not caught up to asking open-ended questions and then allowing you to answer it in a poll-style format. So that's why we use our Jamboard so that you can actually see the question while you're answering in the chat box. So this one in particular, we're talking about risk mitigation measures, right? So we know that a lot of them have relaxed across our country. And so in addition to good hand hygiene, masking, physical and social distancing, what suggestions do you have for additional risk mitigation measures that cancer survivors can take to reduce their risk of contraction of infectious diseases like flu and COVID-19? besides just locking everybody in a bubble. Exercise as tolerated and fresh air. That is a really good one. And again, thank you so much, Chinny, for working to get all these notes for our Jamboard. Stress management, meditation, therapy. Absolutely. We cannot forget our mental health during, this process and during treatment or during a deadly pandemic. Thank you for that. Healthy eating and mental health care. Absolutely, absolutely. So we will add a section on risk mitigation, additional risk mitigation measures, and we'll add these suggestions. All right, educating the survivor's family and friends. Thank you for that one. So on our microsite, we detail in the vaccine recommendation section that cancer caregivers, family and friends, or anyone living with a cancer survivor or a current cancer patient or someone living with chronic cancer need to be vaccinated as well. And so we really, really, really want to expound upon that it's important to protect those around you as well as yourself. All righty. Good self-care and physical activity and connection with other survivors. I love that. Having that, going back to that support group, I think it's important. We're definitely gonna add a section on that, but having people to be able to talk to, and also, like Leeann said, someone may be able to go to your vaccine appointment with you. Alrighty. And our last question, how can we improve the cultural appropriateness of our microsite? Again, I just want to reiterate, we want to make sure it's culturally appropriate and linguistically appropriate. You will be able to view the microsite once we make these edits, and you can also email us at shc@nmqf.org. I believe Keiko put that email address up at the top when we started. So please feel free if you have any additional suggestions or any additional feedback outside of today. And also add support group for caregivers, absolutely. And I should also mention that one of the ways that we brainstorm how we get feedback on the cultural appropriateness of the website is, holding this interactive session. This is a non-cultural published, but I did notice that on your screenshots, the white text on yellow and blue backgrounds is hard to read. That maybe the background colors could be doctored. That is actually appropriate for linguistics, right? We want to make sure that we're being inclusive of every seeing person, and making sure that we have that, what is it called, juxtaposition in those colors. So we'll definitely take that feedback to our communications team. They're really good about playing with those colors. Thank you, Ray. I appreciate that. The font size on the site is small. Can there be options to increase the size of the font? So we have increased it, I think, to the max on the back end. I also would encourage you, depending on the platform that you're working with, it may be, differences in Safari or Google Chrome or Edge or Firefox, but also maximizing that screen for your actual viewing, if you will. But we will definitely try to test this on different screens because we've gotten that feedback before and we've maximized it to, I think, the max size that we can. So we'll definitely continue some testing to understand what else we can do. So thank you for that. And if there's nothing else, we have exactly 10 minutes for Q&A. So thank you guys so much for your feedback. I truly, truly appreciate it. I know the team does as well. So I will ask all of the panelists to sort of proverbially come back in the room, if you will. And if you have any questions, please do put them in the Q&A box. But we did have one pre-submitted question. And the gist of it was basically, what is the relation to cancer and vaccinations? Now, we just had a long talk about cancer and vaccines, but maybe there's some additional things we could add, I guess, from Dr. Doroshow or Dr. Fiscus.
I'm wondering, and Dr. Fiscus, let me know what you think. I'm wondering if there's a subtext to that question about concerns about vaccines causing cancer. That's something that many of my patients have asked me about, especially when it comes to the COVID vaccine, as some of them noticed that they were diagnosed with cancer soon after receiving the COVID vaccine. So I just want to openly address that we have no evidence that the COVID vaccine or really any other vaccine causes cancer.
And I'll just add to that. So, it's where your mind naturally goes if something happens directly after something else happening, which is why we do such enormous studies around vaccine safety. And every vaccine that we have ever used has undergone continuous safety monitoring forever. We've had vaccines in this country for over 200 years now, which a lot of people don't realize that vaccines have been around for that long. And so they continue to be monitored very closely, including the COVID-19 vaccines. And when there's what's called a signal, when it looks like different people are reporting the same thing after getting a vaccine, then that triggers an investigation to go and look and make sure that there isn't some relationship between that vaccine and whatever the outcome was. And as Dr. Doroshow said, there has not been any relationship between the development of cancer and any of the vaccinations that we give routinely in the United States, including the COVID-19 vaccines. Thanks.
Thank you both for expounding upon that. I'm glad you picked that up, Dr. Doroshow, because I think that was the subtext to the question. And there was a question in the chat. Would this recording be posted later today? I'm not quite sure if we have. Yes, thank you. Thank you, Keiko. It will be posted later today. On the actual microsite, it'll probably be posted around Wednesday next week, just so we can make sure everything's cleaned up. So yeah, look for it on our YouTube at National Minority Quality Forum on YouTube. While we wait for others to jump in the Q&A box, I just wanted to ask Dr. Fiscus if you could kind of give us a quick overview, if you will, of the new babies from Omicron and what we're seeing in terms of outcomes.
So, are you talking about
the variants? Yeah.
Oh, the variants.
Yeah.
Oh, the new variants. So, we track these, CDC tracks these very carefully. Then, and to be clear, there are thousands of variants of the SARS-CoV-2 virus at this point, but there's just a handful of those that are considered to be variants that are potentially threatening to us. And those are the ones that they track really carefully. So over the past several weeks, we've been in this little bit of a surge from the variants that are BA 2.1. Blah, blah, blah. There's lots of twos, basically BA2. What is happening now is there's been an increase in a variant BA4, an increase in variant BA5 that has primarily been in the United Kingdom. And this is typically what we see. We see a surge come up in the United Kingdom, and then about 6 weeks later or so, then we get it here. So these BA4, BA5 variants are the most quickly spread of any of the variants that they have seen so far. And there's concern that these BA4-5 variants are better at being able to get around our immune protections than what some of the previous viral variants have been. So that's concerning, which is why it's so important to continue to wear masks when you're in public and wash your hands and keep your distance and not be in big gatherings, and also to make sure that you are up to date with the COVID-19 vaccine recommendations, because even if some of that protection has gone away a little bit, some protection is better than zero protection. And what we really want to do is keep people out of the hospital and alive. And so it's important to go out and get those boosters like we discussed. The other thing to keep in mind is that it is not at all unusual. As a matter of fact, it's kind of the standard when vaccines come out for them to be pretty good, and then we learn more and they can make vaccines that are better and better and better over time. We've seen that with measles, mumps, and rubella vaccine. We've seen it with HPV vaccine. We've seen it with polio vaccines. It's the same for this. We're just living in real time with this. So as this pandemic continues to evolve, the vaccines will continue to do work, continue to do studies, continue to refine the technology that's there. And they're also, trying to think ahead to what the next variants could be, so that they're developing vaccines that may be more universal. But for right now, perfect is the enemy of good, and we should be getting the vaccines that we have available to us to protect us the best way we can.
Thank you so much, Dr. Fiscus. Well, I don't see any more questions coming in through the chat or the Q&A. So I really, really want to thank all of the panelists for an excellent presentation. Dr. Doroshow, Dr. Fiscus, Leeann, thank you for joining us and lending us this hour. And thank you to all of our audience members and participants. And you'll be hearing from us soon. Bye. Have a good weekend.